Alright, this is the second lecture on diuretics. First of all, we're going to be discussing thiazide diuretics, potassium-sparing diuretics, osmotic diuretics, and antidiuretic hormone antagonists. So, we need to know where these are taking their effect. So, thiazide diuretics. You can find them on here. Here are the thiazides. Thiazide diuretics are taking their effect up here in the distal convoluted tubule, and here's distal convoluted tubule, and we'll talk more about those later, of course. Then we have our potassium-sparing diuretics, also taking their effect here. More in the collecting tubule though. And then we have our osmotic diuretics, which are, I'm not seeing on this list. I'm not going to make assumptions. We'll come back over that when I figure that out. And then we have our antidiuretic hormone antagonists here in the collecting tubule as well. So thiazides, distal convoluted tubule, potassium sparing here in the collecting tubule, and then antidiuretic antagonists in the collecting tubule. And wanting to think that the osmotic is mannitol, but for some reason that's evading my mind at the moment. Okay, so again, in the earlier lecture we already talked about carbonic anhydrase inhibitors, we already talked about loop diuretics. Now on to thiazides. So thiazides, like hydrochlorothiazide, thiazide-like diuretics like chlorothalidone. What do? They inhibit the sodium chlorine transporter in the distal convoluted tubule. So, distal convoluted tubule, sodium chloride transporter. See that right there? Modest increase in sodium chloride excretion, mild potassium wasting, hypokalemic, metabolic alkalosis. So far, notice that carbonic anhydrase inhibitors, they had the hyperchloremic metabolic acidosis, whereas the loop diuretics had hypokalemic metabolic acidosis. And now if you look down here, you'll also see similar situation here with the hypokalemic metabolic alkalosis. So both thiazides and loop diuretics have the hypokalemic metabolic alkalosis, whereas the carbonic anhydrase inhibitor is the one that has the hyperchloremic metabolic acidosis. So alkalosis, acidosis, potassium, chlorine, hyper and hypo. Okay, so more about thiazides. Hypertension, you're going to use them in the case of hypertension. You're going to use them, looks like potassium-containing renal stones, nephrogenic diabetes insipidus. Comments about these is that there is both oral and IV preparations. Duration of action depends on the agent, 6 to 50. Hypokalemic metabolic alkalosis, as we already mentioned earlier, hyperglycemia, hyponatremia, hyperuricemia. Also going to be discussing in this potassium-sparing diuretics. So, for example, spironolactone or amiloride. And for these ones, we have the selective aldosterone antagonist in the collecting duct or block the sodium channel in the collecting duct. So going up here, here's our collecting duct, and this says that it either selective aldosterone antagonist in the collecting duct or it blocks epithelial sodium channel. So sodium channel, here's the antidiuretic hormone taking effect there. This is probably the sodium channel, I'm guessing. So yeah, you can see those effects there. And reduces the sodium retention and potassium wasting. is its effects. So I guess it reduces sodium retention. So you get rid of that, and you also waste the potassium. Hyperaldosteronism is one of the things that it's useful for. So if somebody does not have enough aldosterone, you can give them this because it's basically aldosterone. It basically blocks aldosterone. So, hopefully I didn't word that wrong. Hyperaldosteronism means they have too much aldosterone, and so this can get rid of their aldosterone. Also useful in hypokalemia. Yep, good stuff. And oral only, slow onset of action. So that's probably important notes there. Duration 24 to 48 hours. Hyperkalemia, gynecomastia. Remember that this aldosterone ends in "-one", similar as testosterone. That can kind of help you memorize or remember that these have to do with hormones. So this particular one can cause gynecomastia. Potentiate potassium sparing agent toxicity. Okay, so now for osmotic diuretics like mannitol, and I was right. So this is talking about this one right here. So mannitol osmotically pulls water into the extravascular space, then into the urine. So essentially what this is it just has like it's like an ion in here, and it attracts water to it. And so it's going to pull the water in here, and the water is going to travel through, and it's eventually going to get peed out. Mannitol is going to get peed out. Increases in urinary flow, reduces brain volume and intraocular pressure. Good stuff. Increased intracranial. These are some of the things it's useful for. It's useful for increased intracranial or intraocular pressure, acute kidney injury, or rhabdomyolysis. It's like muscle hurt, pain, destruction or something. This is only given IV. Can have a side effect of nausea, vomiting. This is the only one so far that I'm seeing the side effects of nausea, vomiting, headache, initial hyponatremia, which means you get rid of too much salt, or hyper. Then you get hypernatremia. So first of all, you get too much salt, and then your body freaks out and then holds on to too much salt. So lastly, we have our vasopressin antagonist. This is conivaptan and tolvaptan. And this is an antagonist at basically those different receptors, V1, V2, antidiuretic receptors in the collecting tubule. It reduces water absorption, increases plasma sodium. Hypernatremia is useful for hypernatremia, heart failure, SIADH. ADH stands for antidiuretic hormone. And also it can be given IV. Conivaptan is IV, or oral is tolvaptan. Think toll, T for talking. Talking happens in your mouth. I don't know, maybe that'll help. Remember polyuria, thirst, and hypernatremia. Okay, this is basically just another way of showing what we talked about earlier. So one, these are your calcium inhibitors, and so that's going to be taking effect right there. Happens in the proximal tubule. 2, it's your osmotic. So that was like your mannitol. That's really the entire tubule, but they put it there. Next is your loop diuretics. So that was 3. It happens in the thick ascending limb right here. Next is your thiazides. So that happens right here, distal convoluted tubule. Early distal, I guess. Then you have your potassium-sparing diuretics. Potassium-sparing diuretics, that happens in your early collecting duct. So here's your early collecting duct here. And then you have your antidiuretic hormone antagonists. And that happens in your collecting duct as well. So I guess antidiuretic hormone antagonists, ADH antagonists, collecting duct. This shows some of the actual things that are occurring here, as far as its action, almost like on the cells in the tubes. Not going to go into that because I don't think it's super high yield. It's more physiology stuff. But there it is, in case you want to look at it. actually kind of thinking, I want to look at this for a second because I'm thinking that perhaps this got, no, it's not cut off. Okay, we're fine. Then you got your thiazides showing the same thing here. Sorry. Thiazides here, kind of showing the same thing where it's taking its effect, and then your potassium sparing. You can look at that later. This is another breakdown, just showing the same kind of thing we talked about earlier, but just if you wanted to really keep track of where these things are happening. So your calcium inhibitors like acetazolamide, sorry, not calcium, goodness gracious, I thought that was wrong. Carbonic anhydrase, goodness gracious. So this first one I said earlier was calcium. It's not calcium, it's carbonic anhydrase inhibitors. This is talking about what it's useful for. So inhibits the carbonic anhydrase in the proximal convoluted tubule, brush border, intercellular, and other tissues. So that's taking place right there. Useful for glaucoma, aqueous humor, decreases aqueous humor secretion, acute mountain sickness, metabolic alkalosis, all these things we talked about earlier. It's all here. Our osmotic, like mannitol, so that one is happening right here. And this is freely filtered and poorly reabsorbed, so which means that it really easily passes through the glomerulus. Whoa. Really easily passes through the glomerulus like this, but it doesn't get reabsorbed. Going back this way. So it easily passes this way, but does not go this way. Increases tubular osmolality, which means it puts a lot of osmotic pressure in here, which draws a lot of water in, and prevents the water then from being reabsorbed back this way. Useful things is increases urine flow in solute overload, hemolysis, rhabdomyolysis, all those kinds of things. Decreases intracranial pressure, decreases interocular pressure. This is the second one we discussed that decreases interocular pressure. The other thing that was associated was this one, decreases the aqueous humor secretion, which was the acetazolamide. Also helps with pulmonary edema, hypovolemia, hypernatremia, and it's got this nausea vomiting thing associated with it. So that's the only one that I saw that had the nausea and vomiting was the mannitol. Loop diuretics, furosemide, anthracnic acid, and torsemide. This one and this one both have to do with sulfur. This one's not. So if this person has a sulfur allergy, you want to give them this guy right here. What does it do? It inhibits the sodium potassium chloride cotransporter in the thick ascending limb. So what we're looking at here is right there. So this section, I guess this section here. So edematous states, heart failure, ascites, pulmonary edema, hypertension, hypercalcemia, hypokalemic metabolic alkalosis. Same thing as the thiazides as well, which had the hypokalemic metabolic alkalosis as well. So both of these have the metabolic hypokalemic alkalosis. Going down now to thiazides. Here, thiazides. You can almost remember this order. It might be helpful because it looks like it's just walking its way down the limb. 1, 2, 3, 4, and so forth. So anyway, now before we have our thiazides. So those are up here. So thiazides, hydrochlorothiazides. This is having its effect on the distal convoluted tubule. It inhibits the sodium chlorine cotransporter. And side effect is going to be hypertension, edematous, not side effect, excuse me. It treats hypertension, edematous states, lose the effectiveness of the GFR, lose effectiveness when GFR, glomerular filtration rate, is very low, in which case switch to loops. Hyponatremia, all that stuff. You can read it. Chat about sulfa allergies. Now for our potassium sparing. So now we're coming over here. I think we're in our yeah, that's the region right there. So there it is. Potassium sparing, this is like spironolactone, eplerenone, amiloride. This acts in the cortical collecting tubules, blocks aldosterone receptors, spironolactone, eplerenone, block the sodium channels. Adjunct with other diuretics to prevent potassium loss, hyperaldosteronism, anti-androgen. Spironolactone is anti-androgen, so that's where we worry about the gynecomastia. Hyperkalemia, endocrine effects such as gynecomastia. These are all the side effects, things you're worried about. Okay, now going on to the last one here, the antidiuretic hormone antagonists. So we're looking right there. This is things like dimethylcycline and lithium, and these are V2 antagonists. So treating here SI-ADH with dimethylcycline, and some of the side effects are bone teeth abnormalities. We know that's what happens with tetracyclines, because this is a tetracycline. Nephrogenic diabetes insipidus, lithium. Those are some of the side effects you worry about. All right, so just to be aware what these different do. Carbonic anhydrase inhibitors, they are going to increase your sodium chloride in your urine. So increase, so basically you pee out sodium chloride a little bit. It's going to really increase your bicarb, sodium bicarb in your urine. It's going to have a little bit of an increase in potassium in your urine, and it's going to have a little bit of an increase in calcium in your urine, and it's going to, overall it's going to decrease your body's pH. There's only one other one that decreases your body pH, and that is your potassium sparing. So both your potassium sparing and your carbonic anhydrase are going to be decreasing your body pH, which means making your blood more acidic. So when you're looking at loop diuretics, so loop diuretics taking their effect right here, thick ascending limb, those big time are going to fill your urine with sodium and chloride. Well, that makes sense since they have to do with the sodium potassium chloride pump. In this case, it can decrease. Remember, this one increased your sodium bicarb. This one can decrease your urinary sodium bicarb, or can leave it unchanged. It's going to increase your urinary potassium. Remember, all of these increase your urinary potassium except for, of course, the potassium sparing, which is, of course, going to decrease your urinary because that holds on to potassium. All the other ones are going to make you pee out more potassium. Loop diuretics also increase your calcium. So the two that are going to increase calcium are going to be your carbonic anhydrase inhibitors and your loop diuretics, whereas your thiazides are going to have you get rid of your calcium. Loop diuretics are going to increase your body's pH, making your blood more alkalinic. Remember these two, we talked about that earlier, metabolic alkalosis. That's an important thing to be aware of, is both the loop diuretics and thiazides increase your alkalinity, or your body pH. Okay, your thiazides, that's going to get rid of some sodium chloride. It doesn't really have any effect on bicarb. This one increases your urinary potassium along with all the other ones except for the potassium sparing. It's going to decrease your calcium. So thiazides are really a good thing to do if someone's hypercalcemic, because it's the only one that decreases your urine. Reverse that. If someone is hypocalcemic, you could give them a thiazide because it's going to decrease their urinary calcium. So that's good to be aware of. So hold on to your calcium a little bit more. And again, this one is going to increase your body pH, making it more alkalinic. All right, now potassium sparing does dump out a little bit of sodium chloride. Doesn't really have any effect with the bicarb. Decreases your potassium dumping in your pee, which is really significant because that's the whole point of the name, potassium sparing. No effect on your urinary calcium, and decreases your body pH. Of course, here you can see where all these take effect. So carbonic anhydrase inhibitors, of course, take effect right here. It's like acetazolamide. Loop diuretics are going to take their effect right here in your thick ascending limb. Thiazides are going to take their effect right over here, distal convoluted tubule. And your potassium sparing drugs are going to take their effect way over here in the collecting tubule. Here's another kind of breakdown. I'm not actually going to talk through all this, but just kind of this goes into way more depth as far as what's actually occurring here, talking about the different effects. So I will talk about it just a little bit. So first of all, we're looking here. This is like, oops, this is way up here, kind of some nephron physiology, showing here that angiotensin II and acetazolamide are going to have some effects here. This looks like pre-glomerular. So acetazolamide knocking out this carbonic anhydrase, and angiotensin II having the effect on this here. I'm not going to go into this because it takes too long to really understand and explain. Thiazide diuretics knocking this out. Yeah, you can go over this on your own time. Something just kind of comparing some of these. I think the main thing to really take out of here that was made is probably this comments thing, and also understanding that chlorothalidone is just, it lasts forever, like 40 to 60 hours. That's a really, really long time. Looks like nocturia in some patients due to long half-life, meaning that they have to pee during the nighttime because it lasts so long. Also knowing that hydrochlorothiazide is the very cheapest. Any other things that are important on here? I'm not really seeing too many other that are standing out to me. Torsemide, hepatically cleared. Just remember that one. Yeah. All right, so a little discussion about mannitol. Its mechanism is that it's an osmotic diuretic. It increases the tubular fluid osmolality. So this is where it has its effect. Actually, it takes effect everywhere, but basically it draws fluid into here because it easily passes from here to here, but then it does not easily pass from here to here, and so it creates osmotic pressure here, which draws fluid into this guy and makes you pee more. Increased tubular fluid osmolality leads to an increase in urine flow, a decrease in intracranial interocular pressure. Remember, this was the one that can cause nausea and whatnot, if I'm remembering correctly. Clinical use is drug overdose, elevated intracranial interocular pressure. So apparently if somebody takes too many drugs, they can take this, and hopefully this will help them get rid of the drugs, I'm guessing. Toxicity can cause pulmonary edema, dehydration, and it's contraindicated in anuria. So if somebody's not able to pee, don't give them this because that'll be really bad. And also toxicity can cause heart failure. Thiazide diuretics, taking their effect here in the distal convoluted tubule. Some examples of these is chlorothalidone, which is I think the one that lasts a really long time, and hydrochlorothiazide, which is a really cheap one. Mechanism is that it inhibits the sodium chlorine reabsorption in early distal convoluted tubule, leading to a decreased diluting capacity of the nephron, which decreases calcium excretion. So, yeah. Clinical use: hypertension, heart failure, idiopathic hypercalciuria. I hadn't seen that before, so that's a new one for me. So thiazide diuretics, think if somebody has too much calcium, you want to get rid of that calcium, which is what this was talking about. So thiazide dumps out the calcium if somebody has too much calcium. Nephrogenic diabetes insipidus, osteoporosis. Other uses. Toxicity, hypokalemic metabolic alkalosis. Remember, there was two associated with metabolic alkalosis. Going back to this, remember those two alkalotic states or whatever. So these two right here. Thiazides and loop diuretics. Both are going to increase the body pH, making your blood more alkalytic. Also can cause hyponatremia, hyperglycemia, hyperlipidemia, hyperuricemia, hypercalcemia, and also associated with sulfa allergy. Unless you use that, oh yeah, sulfa allergy, we'll worry about that. So hypergluc, I guess the G is for glycemia, the L is for lipidemia, the U is for uricemia, and the C is for calcemia. Hypergluc, okay, whatever. All right, so potassium-sparing diuretics. These are going to have their effects over here on the distal convoluted, or excuse me, on the collecting duct. Oops. These are ones that end in -one, like spironolactone and eplerenone, aldosterone, competitive. They are competitive aldosterone receptor antagonists in cortical collecting tubule. So they antagonize aldosterone. And looking up here, it says spironolactone, eplerenone, trimetrine, and amiloride. The potassium stays, because it has got STA, potassium stays, spironolactone, and trimetrine and amiloride. Okay, all right. So it says trimetrine and amiloride act at the same part of the tubule by blocking sodium channels in the cortical collecting tubule. Okay, good to know. So essentially, they block these sodium channels, and so sodium can't get reabsorbed, and so the fluid goes in, and you end up having more pee. And hyperaldosteronism is one of the side effects, or excuse me, one of the uses. So somebody has too much aldosterone, you give them this, it decreases the effects of the aldosterone, and also potassium depletion and heart failure, other clinical uses. Toxicity can lead to hyperkalemia, and which can lead to arrhythmias. Endocrine effects with spironolactone, gynecomastia, antiandrogen effects. This is kind of a break. This looks extremely complicated, but it's really not that complicated. Basically, all you really need to know is that if somebody is black, you're going to give them thiazide type diuretic or a CCB, which is a calcium channel blocker. So black person, thiazide type diuretic or calcium channel blocker. If they are like older and less than 6 years. Oh, hold on here. Well, basically all I got from this is you want to give people with hypertension an ACE inhibitor or an ARB, unless they're black, in which case you want to give them a thiazide type diuretic or a calcium channel blocker. And you can work your way through the rest of that. It looks, maybe it is more complicated than I thought it was. So this is kind of a breakdown of some of the other effects. The main one I wanted to focus on, though, was aldosterone. Just understanding this angiotensinogen, angiotensin 1, angiotensin 2 thing here. So basically, your liver makes something called angiotensinogen, renin, which is released from your kidneys, or maybe has its effect on the kidneys, whatever, is going to cleave angiotensinogen into angiotensin 1, and then angiotensin converting enzyme, which comes from your lungs and your kidneys, I guess, converts angiotensin 1 into angiotensin 2, and angiotensin 2 is the thing that goes and activates aldosterone, and aldosterone is what you end up inhibiting with your like spironolactone and eplerenone drugs. So that's kind of the point there. But there's other good information on here as well. Again, this is kind of the just filling that in, where the aldosterone kind of has its effect and whatnot. This is just a review of what we talked about earlier. I would recommend going over this again. Make sure you understand this is all the high yield information, and that's the end.